I'm Michael Kleiner, Director of the Office of Emergency Medical Services. I'd like to talk with you today about the Department of Public Health's initiative to bring the paramedic level of EMS service to those few remaining areas of Connecticut that don't have it. The office has a statutory responsibility to develop a statewide EMS system. That statewide EMS system should conform to national standards. It should provide for local flexibility about how those standards can be met. But most importantly, it should provide for an efficient and effective uniform level of service to all of Connecticut's residents. Early EMS systems were designed merely to provide a means of conveying patients from the site of their accident or illness to where a physician could attend to them. Modern EMS systems were originally designed to reduce death and disability due to heart attack in the pre-hospital setting. How well an EMS system responds to life-threatening heart attacks and how those patients ultimately fare is one of the ways we measure how good a given EMS system is. We know that if an EMS system is dealing effectively with pre-hospital cardiac arrest situations, it's probably dealing effectively with other medical emergencies as well. Over the past 25 years, emergency medical research has identified the critical components that can influence the outcome in out-of-hospital cardiac arrest cases. In 1992, the American Heart Association organized all of that research into a concept called the chain of survival. The chain of survival defines what must occur for an individual victim of pre-hospital cardiac arrest to have the best chance to survive, and what must occur to reduce overall death and disability from heart attacks. The links in the chain of survival are early EMS system access. This link in the chain is the public's responsibility. They must be aware of the signs and symptoms of a possible heart attack and must quickly activate the EMS system by calling 911. Early CPR. In sudden out-of-hospital cardiac arrest, irreversible brain damage begins to occur within 4 to 6 minutes. This 4 to 6 minute time period can be significantly extended, however, if someone begins CPR. CPR can be initiated by a trained bystander, by someone who is being coached over the 911 phone line by a trained emergency medical dispatcher, or by trained EMS first responders. No matter who does it, CPR must commence within 4 to 6 minutes before irreversible damage begins to occur. Early defibrillation. The sudden collapse of a victim of out-of-hospital cardiac arrest is usually caused by ventricular fibrillation, chaotic electrical activity within the heart that prevents it from pumping effectively. This condition can sometimes be reversed by defibrillation, the administration of an electrical shock to the heart. Defibrillation used to be a pre-hospital skill that was limited to paramedics. But because of the need to deliver this life-saving intervention more quickly, defibrillators have been designed that could be safely used by first responders, EMTs, and even members of the general public. Early advanced life support. In addition to defibrillation, out-of-hospital cardiac arrest victims also require the administration of a range of powerful drugs that can only be administered by fully trained paramedics. Extensive studies have shown that, to be effective, these drugs must be started within 12 to 15 minutes of the cardiac arrest. For the most part, all of the elements of an effective EMS system are already in place in Connecticut. There's universal enhanced 911 access throughout the state. All of the state's towns are served by at least a basic life support level of service. The EMTs who provide basic life support may be part of volunteer services, municipal services, or commercial ambulance services. The life support services that EMTs provide is being increasingly augmented by medical response technicians serving as first responders. Most of Connecticut's towns have first responder services, which in many cases are now equipped and trained to use automatic defibrillators. In terms of both geography and population, approximately 10 to 20% of Connecticut does not have available paramedic services. The lack of this critical link in the chain of survival means that the likelihood of survival from an out-of-hospital cardiac arrest in Connecticut is significantly influenced by where someone lives or where they may happen to travel. I'm at a town border in Connecticut. If I happen to have a cardiac arrest right here, paramedic service would be available to me. If I had a cardiac arrest here, it wouldn't be. In 1994, the Department of Public Health formed a task force to develop a deployment model for effective, cost-efficient, statewide paramedic coverage. It It was recognized early on that the deliberations of the task force would be influenced both by economics and by the concern about unfunded state mandates at the local level. An innovative deployment model has been developed that provides for statewide paramedic coverage, which is both efficient and cost-effective. It is not a one-size-fits-all approach. It is a regional paramedic intercept approach which divides unserved areas into population groupings of approximately 50,000 people. The model gives local EMS organizations an opportunity to directly assume the responsibility for providing paramedic coverage to an unserved area. Also, local EMS organizations can enter into partnerships with other EMS organizations to provide paramedic coverage to a multi-town unserved area. And finally, paramedic coverage may be supplied by an EMS organization which has applied for or been assigned to provide paramedic coverage to an unserved area. The implementation of this model will be accomplished through the existing need for service process, which in and of itself requires a demonstration that a need exists for a given service. In addition, the need for service process requires local input and recommendations regarding who will provide the paramedic level of coverage in an area. With regard to the recommended deployment model and the rules under which it must be implemented, I'd like to address the one question I usually hear first. Who is going to pay for it? The EMS organization that provides paramedic service to an unserved area will bear the cost for deploying paramedic resources. The paramedic services they provide will be paid for by those who use the service. We also know, based on historical payer data, that we can expect insurance companies to pay approximately 70% of the service cost for the consumer. Medicare reimbursement for paramedic intercept service has been the topic of considerable discussion lately. While it is true that Medicare will not pay for independent bills for paramedic intercept service, both the state's Medicare insurance carrier and the Federal Health Care Finance Administration have identified a method of combining the ambulance bill with the paramedic intercept bill, which Medicare will pay. Many services are already using this method, much to the advantage of their senior citizens. We know that many of those people that access the EMS system can be well cared for by MRTs and EMTs. So in addition to ensuring that paramedic level services are available everywhere in Connecticut, we must also do what we can to ensure that this level of EMS resource is used appropriately. Trained emergency medical dispatchers, using medically approved EMS dispatch protocols, are making safe decisions about what level of EMS resource should be dispatched to a reported medical emergency. Many EMS systems have also developed field protocols for EMTs that define when paramedics should be summoned and when their response can be safely discontinued. The EMS Advisory Board has approved the American Society for Testing and Materials Standard for emergency medical dispatch services in Connecticut, and the board's Medical Advisory Committee is right now looking at paramedic utilization protocols. How has the addition of the paramedic link in the chain of survival worked here in Connecticut? Is it really worth the cost? Does it work at all in rural areas? Is there a difference in the outcome of patients? What's been the experience of EMTs and MRTs where paramedic services have been implemented? Are their roles diminished? Have local volunteer services lost membership or gone out of business? Let's listen to some people who can answer these questions through their firsthand, real-life experience.
Well, I guess we go back from the beginning. I've been a member up here for, 24, 25 years. I run the ambulance for about 22 out of that 20-some odd years as a member. And when the system started, it was basically basic first aid, pick up and haul, you know. For 1986, my life was saved by paramedics, EMTs combined, working together. I survived a major heart attack, lived through the night after my heart stopping 3 times, and then everybody that has a heart attack needs that extra chance to survive. And if paramedic intercept was the way to do it, that was the way to go, and I'm strongly for it, you know. Like I say, I survived one in 86, and then just recently in November of 95, the day after Thanksgiving to be exact, I went down again with sudden cardiac death, and the system worked again. You know, I had somebody there that knew CPR, although it wasn't presently trained, certified, but knew it. Got that going, got the system into works with 911, the paramedics came, And I'm here again today. Same thing, basically. You know, so the paramedic intercept system does work, and it does not put anybody out of business. Oakdale's been in business for 35 years. We're still going strong with the ambulance, with the fire, and with the paramedics. And nobody has a problem with it. It's giving everybody out there that needs us a better shot to end up like I did, you know, being a survivor instead of a statistic on paper that, well, we tried and it didn't make it, you know, basically. You know. I have no complaints. I'm all for it. You know, I keep telling everybody I'm a cat. I got 9 lives. I've used up 2, and I'm working on 3 now, and hopefully we'll shoot for number 4. I want to keep that a long way off yet. You know, everybody up here in this department, you know, works well with paramedics. They have from the beginning. You know, in the beginning, when you try something, whenever something new comes around, we're all a little bit skeptic. You know, sometimes we sit and say, you know, do we really want this? Well, you know, you have to try something. If what you have is working, but not working as well as you like, you have to try something new.
The day after Christmas, I started to experience some chest pains. Was moving my family from one location to another, and the pains got pretty bad. Within a few minutes, I was on the phone to 911. Soon after calling 911, a first response team showed up. They came in, they evaluated my situation, and quickly decided that they needed a paramedic on the scene. Someone maybe with a little more expertise, but they were good at spotting that and realizing that I needed one. They proceeded to get me loaded into the ambulance, and within a few minutes the paramedic was on the scene, joined us in the ambulance, and it was a real comforting situation for me suddenly. He had a very professional manner about him. He was able to get my vital signs, an accurate reading on them. He immediately was online with the hospital and administered, you know, some medication to help me with my heart attack. He proceeded to put the chest leads on for the cardiac monitor. By the time I got to the hospital, it was a short ride, about 10 minutes. I was, you know, set up pretty well for the folks in the emergency room. I did hear one of the nurses say a few days after all this was that the paramedic had actually bought me a few extra minutes by you know, through his efforts. So you know, my kids are happy, I'm here, and the paramedic was as responsible for saving my life as anybody, and I firmly believe that.
I've been doing this for 8 years, and since when the paramedics came around, there was a great concern. There was going to be a lot of problems with the paramedics taking over. Maybe the company coming in and taking over our transports and things like that, and it's not true whatsoever. Paramedics are great. I really enjoy working with them. I've seen a great survival rate increase in the area. I've also become personal friends with a lot of them. They've also helped me with my BLS skills.
It's been working out well that we've been working as a team with volunteer EMTs in the area from the fire departments and ambulance services. Because naturally they are first. We are coming out from the hospital. It's been a favorable partnership. Again, I haven't run into any severe problems or any even minor problems working with the volunteer EMTs around here. Like I said, it's mainly been a good partnership because of some of their earlier BLS interventions, again, buying us time to get out on scene, because some of our transport times out to their locations can be as much as 20 to 25 minutes. So without their good BLS care, we wouldn't have much to work with in a lot of cases.
I'm the medical director of Day Kimball Hospital's emergency department, and we serve as a hospital 77,000 patients approximately in an area of 400 some odd square miles. In this area, we've for a long time been looking at developing an intact chain of survival for patients with cardiac and other emergencies. And the goal was to develop a chain of survival all the way from the first responders to the hospital that incorporates all levels of care, providing the best care of patients with acute cardiac and traumatic emergencies. One thing that we questioned was, would this increase survival before the advent of first responder and ambulance defibrillation by basic EMTDs? We had no survivors. To put the defibrillators out in the field, and again, we continued to clock our outcomes. And of another 300 or 400 patients over the ensuing 3 or 4 years, we may have had 2 or 3 patients who survived to reach the hospital with a perfusing rhythm. However, no one left the hospital alive. The link of the chain we were missing was a paramedic intervention. And basically the volunteer EMS providers, Day Kimball Hospital, the ambulance providers, the fire chiefs, we got together and worked out a plan to provide paramedic intercept service in our community. We then put the paramedic in place just about a year ago, and we are now applying for a PSA, which will allow us to provide service to our area geographically and define our boundaries. And that's in process now. But the paramedic is now in just the 9 or 10, almost a year, the year that we've been in place, we have now had for the first time people surviving to leave the hospital of cardiac arrests. And the number is about 5 at this point, 5 survivors of cardiac arrests, and several survivors of medical emergencies that are not cardiac arrests. We had one person who had a cafe coronary who was in cardiac and pulmonary arrest on arrival of the basic units. They could not establish an airway, and the medic, using a McGill forceps, removed the foreign body, and the patient survived to reach the hospital and certainly would have died otherwise. We had a number of patients who had multiple trauma, who received field interventions far earlier than they would otherwise have. And overall, for the first time, we are now seeing survivors of cardiac arrest, which in my 9+ years experience as a director of this department, we have never before seen. The key to our success was that we brought all of the parties together who were involved in developing a paramedic intercept program. We brought the volunteer fire providers, volunteer ambulance providers, the non-charging volunteers, the charging volunteers, the hospital, local government. We brought everyone together, including the commercial provider, and managed to develop a win-win strategy where some of the concerns that some individuals in the group might have had were negotiated through, and basically we grew it from the grassroots up.
They realized over a period of time that they didn't have to do a 20-minute transport with a seizing child. Paramedics can stop seizures. And they didn't, and that the diabetic, unresponsive patient who was hypoglycemic could be awake and talking by the time that he got to the hospital. And of course the most dramatic is congestive heart failure patients who are in pulmonary edema, and we all would just pray that they could get to the hospital on time. And through the miracle of morphine and Lasix in the field, those people, respiratory distress is fairly well taken care of before they even get to the hospital. The question that was just asked of me is if the semi-automatic defibrillators and the training involved, PTLs and all the things that basic life support people can do, how that's impacted on the pre-hospital care. And of course it has. Of course we have better care. But we also have to remember that as good as the semi-automatic defibrillator is, it's only a Band-Aid for that particular problem. The person who's in ventricular fibrillation or ventricular tachycardia needs to be converted very quickly by using the defibrillator. But if they don't have the correct cardiac medications to reverse the reason for them having gone into cardiac arrest in the first place, then they're going to refibrillate. And so if you're traveling with a patient that you converted and you have a 20 or 25-minute ride to the hospital, you best want to have a paramedic coming because they still need those cardiac drugs. They're going to refibrillate. So it's still a team process. It's not as if defibrillation or PTL or any of those skills can replace the paramedic. It just improves the standard of care all the way around, and it's a team effort. Those things save lives. The paramedics need to bring the cardiac medications into the picture too. Basic EMTs breathe for people who can't breathe on their own using a bag valve mask. But now they're using it attached to the paramedic's endotracheal tube. They're working together. They're bringing better care to the community, and they're doing it together, ALS, BLS, a good team. They're doing a really good job.
In addition to its regulatory responsibilities, the Office of Emergency Medical Services has a statutory responsibility to develop a statewide EMS system. In carrying out that responsibility, we must continuously balance what is legitimately government's role against what is unnecessary government intrusion into local affairs. We must ensure that our EMS system and its standards and regulations conform to the established science in the medical literature as well as nationally defined medical standards of care. The chain of survival represents the delivery of the defined standard of care as it relates to out-of-hospital cardiac arrest. By conforming to this standard of care, we will ensure that in Connecticut, for the victims of pre-hospital cardiac arrest, all that can be done will be done. Most importantly, the science has proved that the presence of all of the links in the chain of survival will demonstrably reduce death and disability from pre-hospital heart attacks and cardiac arrest.